somebody. I'm assuming that it's okay to record. I haven't had anybody say otherwise. Thank you. So good evening, everybody, and welcome. So the agenda for today is just going to provide a brief overview and summary of the COVID booster programme, key features of the community pharmacy service. We're going to go over some timelines, and then we're going to talk through the process of completing your expression of interest. And we'll do a Q&A session and just provide an overview of resources. As I said before, I'm joined here by Monica Roper and Umesh Patel from NHS-E&I, and Louise Gatley, Bolton LPC's Chief Officer, Ludwig van Doorn from GMLPC. Next slide. Okay, so in summary, the expression of interest process is now open, and pharmacies wishing to be considered for phase 3 should inform their regional team by submitting an EOI via the portal by 5 p.m. on Wednesday, 28th of July 2021 at the latest. Community pharmacy contractors should carefully consider all the information in the documents before submitting the expression of interest. This is a new service, and so community pharmacy contractors who are currently delivering COVID vaccination services in phase 1 and 2 will need to follow the same EOI process. So regional teams will then go on to prioritise the expressions of interest, taking into account local health needs and access. Next slide. So the key features of the community pharmacy, Les, are as follows. Transition from phase 2 to phase 3. So in order to allow existing community pharmacies to offer further vaccinations, it's the intention that the 2021 LES delivering phase 1 and 2 will be extended until the 31st of October 2021, but community pharmacy sites will not be able to deliver booster vaccinations under that scheme. So in terms of site capacity options, following a successful pilot, community pharmacy contractors can now express an interest in being commissioned to deliver COVID-19 vaccinations from a low capacity site, in addition to the previous medium and large volume options. In terms of indemnity, the government is working closely with the insurance sector to provide support to pharmacy contractors commissioned to deliver phase 3 of the programme. In terms of payment, the item of service fee will continue to be £12.58 per vaccine administered. In addition, a payment of £10 will be made for administration of each vaccination to each patient where the patient is. So this is for patients that are resident in and receives a vaccination at a care home or other residential setting, somebody who's employed or engaged by a care home and receives vaccination at that care home or other residential setting, or for the administration of each vaccine to each housebound patient. Next slide. So in terms of timelines, the expressions of interest from contractors opened on the 14th of July 2021, and at 5 p.m. on the 28th of July, the deadline for pharmacy contractors to advise the Commission's regional teams of proposed sites for designation. So that's when the closure of the expressions of interest process will happen. Between the 28th of July and 4th of August, there will be a prioritisation of the proposed sites by the Commissioner based on the expressions of interest. 5th of August 2021, further expressions of interest from pharmacy contractors will be sought if integrated care system needs are not met. And through August, there will be an assurance of the proposed site to confirm that the proposed site meets the ICS needs and should be commissioned. So I will leave it there and then hand over to Louise for the next part of the presentation. Thank you.
Thanks so much, Roger. Yes, I'm just going to quickly go over a couple of slides here for you. So looking at the timelines, a little bit more detail for you on that, and provide some oversight around the designation process and some of the site capacity information for you as well. What Umesh has asked me to tell you is that, and if you've got any questions on these early slides, you pop those into chat now, please, and we'll pick these up with you straight away at the end of my few slides before Umesh really gets into the nitty-gritty of what he's looking for at the NHS team. So, as Ludwig just mentioned, the window is now open on the portal for you to express your interest in the service, and you access that from the link available in the designation process document. As these expressions of interest start to come in, the NHS team are starting to look at them and to prioritise them. What they're really looking for is who's putting in that expression of interest, which populations those sites will cover. If there's a service there already in place from a PCN or another provider, So really, is that site needed in there to add additional capacity? And finally, can the site potentially meet the requirements of the spec for sign off? This is why it's really important that the level of detail you put into your expression of interest is carefully considered and done properly. One thing for you to consider is that during phase 1 and 2, all sites had a site visit from the NHS EOI team and the GPHC, but depending on the number of expressions of interest that are received and the number of site visits that are required, the early conversations and visits may need to be virtual with a virtual sign-off. That will be followed up at some point with a physical visit to the site, so the NHS EOI team can be assured that you'll meet the requirements of the service spec, and then there'll be further unannounced visits to seek some assurance. So just moving on to my next slide. This document here, this flowchart here can be seen in the designation document again. Not any real detail, but it's worth having a look at because it's a useful flowchart that just shows you how the whole process works from both the pharmacy contractor and the NHS England point of view. Right, so just moving on to the proposed community pharmacy site capacity. The slide here sets out the 3 options that are being put forward for community pharmacies. The low volume option, where there needs to be a commitment to deliver up to 100 vaccines per week, a medium capacity of 350 per week, and a high capacity of 1,000. What is needed for you to deliver will be subject to vaccine supply, but also based around the needs of the population and what commissioners in an area believe that they need. There is some differences in terms of requirements for each volume of site. So for the low volume pharmacies, the service must be on the pharmacy premises, and it's expected that you would need very minimal support in terms of kit to deliver that. Vaccine supply there will be fortnightly, and like the other models, you would need to use the national booking system. For the medium and high community pharmacy sites, there's a preference for NHS premises, so that would or could be your pharmacy where possible. But NHS England do recognise not everyone can do this. Space available in your pharmacies, and some of you might want to look for alternative cost-effective sites. Both the medium and the high volume vaccine delivery sites, the delivery will be weekly, and there'll be some support there with some kit that you may need to deliver that service. And like Ludgett said just a few minutes ago, for all of you, it will be responsibility of you as a site to source your own indemnity insurance, and the national team is working with the insurers to make that as cost effective for you as possible. I'll hand over now to Umesh to take any questions that might have appeared in chat on this section before he moves on to his slide, which will really give you all the detail around what he's looking for from sites. Thank you.
Thanks, Lou. Just open the question. I think there's one question in the chat. If we've submitted already in EOI, can we, I guess, make further comments after this Teams event? The answer to that is possibly not as straightforward as it would seem. So the short answer is there's nothing stopping you from sending an email in to your area team to let them know that you've made your submission and you want to make some additional comments. That there's nothing to stop you doing that. The process is going to be quite a compressed process, and we'll, as NHS England teams, be looking at all the expressions of interest, and there are going to be several of them. So I would suggest, if you are going to make comments, try to keep them brief so we've got a chance to read them. Please don't write War and Peace if you can. So hopefully I've answered that question. Are there any other questions? Should we go to the next slide, please, Lou? Okay, so the reason I've been asked to attend along with Monica is we look at existing sites for sign-off, and I'll partner hand in glove with the GPHC for these site sign-off visits. We have a template that we go through to make sure that we can sign off that dual element of review. From a GPHC perspective, I'm not going to take you all through the standards of premises standards and GPHC professional standards for pharmacists. You'll all be familiar with those. I look at it from the perspective of the contracts service, and we have to make sure that all these the items that we go through in the next slide are all met. If we can't assure anything during a site visit or during a pre-site sign-off, we can seek assurances on the way. So don't feel under pressure if you have a visit and some of your kit's outstanding, or you're waiting for an electrician to put something into your premises. It's not an immediate no. Talk to us. We want to work with you to make sure that we understand where you are. And in the ideal world, you'll say, I'm going to have a light fit in there. I'm going to have power here. I'm going to have a desk over there. We can imagine these things, and that's going to work. If you show me a space in a field and say we're going to build a building there, then it's unlikely that will sign it off. So think carefully about your EOIs. So I'm going to quickly go through the key areas. So I've mentioned NHSEI contractual. The contractual elements are in relation to the LES, and they're also in relation to your standard pharmacy contract. So whatever you need to do in your pharmacy contract that might apply to a COVID site will also apply. The GPHC standards, as I've mentioned, is squarely rooted with our inspectorate, and NHS England feeds and informs the inspectorate. So if we see something that we feel is not in line, we'll have to bring that to your attention, but we'll also need to bring it to the GPHC's attention. The next item that's quite high on the radar is the IPC, the Infection Prevention and Control. Most pharmacists will be pretty good with IPC. However, what I need to, and we'll come into this in more detail in one of the later slides, what I can tell you is, unless you've worked in a clinical setting or a hospital setting, like an aseptic suite or on a ward, or just one of these unusual jobs that exist out there, you might not be up to speed with everything. So we refer you to the PSNC guidance, but also any other guidance that would be that would be relevant for this. Governance, clinical governance, absolutely. You don't need me to labour the point. You're a bunch of pharmacists, we get that. One of the issues that we pick up during our visits, either for sign-off or when we do visits after sites have gone live, is in relation to training. Are the staff working there trained and competent? You may have volunteers, and we will ask about the volunteers training, because there are jobs and roles that they will have that you need to be assured of, because you won't be able to keep an eye on everyone at all times. Again, we'll come into that in more detail. The workforce and staffing levels is absolutely crucial. If you're not able to demonstrate your workforce, then obviously our view of your EOI starts to drop down in terms of credibility. We'll go through what staffing you'll need and where, but in essence, you've got to have people at entry, you've got to have people at reception, you've got to have people showing the patients through the system to make sure they don't get too close together. You've got to make sure questions can be answered, and of course you've got to have your vaccination staff and your observers. The next thing really is about premises. So again, all the standard GPHC premises requirements exist here, but then we've got to look at your premises lease. Is it going to be in your control? So if you are renting any properties, can your landlord come around and have a walk around the premises? I mean, that's never been the case yet, but it's just to make that clear. These are secured premises. We also need to look at security, what the airflow will be like. Now, many of you might not have considered airflow, but if we're having people coming through and it's for COVID vaccinations, all sites, whether it's pharmacy, medical or otherwise, must be able to demonstrate that you can create some airflow through just to make sure that the air is not getting stale. You may have a number of people in those premises sitting for 15 minutes post-vaccination, so that the air's got to flow. Again, we'll come back into premises particulars later. Then, of course, you know, with pharmacists, we're thinking about the overall patient safety and patient confidentiality. I have visited sites where the confidential conversations haven't been quite so confidential, and we have had 1 or 2 concerns raised to NHS England. So it's never ideal. It's absolutely never ideal. And I don't want to hold us to a standard that's impossible. So we will work with you. And the classic example is if I was in a hospital bed, the nurse pulling up a shower curtain around me doesn't suddenly stop the noise of our conversation passing on to the patient next door. So we've got to be realistic about this. And the last thing that I want to pick up on for the key areas is about consent. Consent is absolutely central to all NHS services. For any one of you that have ever had a surgical procedure, you'll know the number of forms that you have to fill in just to demonstrate that you've had consent. That's not the level of consent we're looking for here, but ultimately the clinical supervisor for the site and the registrant undertaking the vaccination must be able to stand up and defend any allegations from a patient who says, well, do you know what, I went through it, but I never consented to it. So please remember the three legs of the stool for consent. It's got to be informed, it's got to be voluntary, and the patient must have capacity. So always bear those points. Now, for the next slides, I'm going to talk quite quickly. Every once in a while, I will stop and ask for questions or pick up from the chat. So could I have the next slide, please, Lou? Okay, so when Monica and I visit a premises, the first thing we do is we start taking notes as we approach the premises, so from the outside. So we look to see, is it big enough? You know, if you're going to do 50 patients a day, is it realistic that that premises space can manage 50? What's the parking like? How will a patient with walking difficulties get to your site? Because you've got to remember, these might not be your regular patients. These might be patients who will go online, book with you and think, do you know what, I can get an appointment at Betty's Pharmacy. It's just across town. I'll get my son-in-law to drop me off. But will it be safe for them? We also look for bus and transport networks as well for those same reasons. We also think about the costs. Now, a big part of this assessment process will look at something called value for money, VFM, you'll hear us throwing around. If there are different sites and one costs, you know, £1,000 a day and one costs £100 a day, and they're both the same every which way, we will look at the cost value for money on those sites. We cannot give you a pound note figure for cost and value because it depends absolutely. So if we set up a site in London, rental costs, premises costs in London are going to be far higher than they are in Bolton, you know, but also, as well as the premises and the rental costs, if those do come into into play, as well as that, you're going to have to think about your fit out costs. So if you have 5 pharmacists and 4 of them can fit out their premises for £1,000 or £2,000, and one of them comes up with a bill for £10,000, we will push back and say, are you sure this is correct? But actually at this stage, because we've got to go so fast, that time for us to come back to you and you to give us a modified answer or a, you know, no, sorry, we can't change that, it's going to be very tight. So please think carefully about your costs and provide your best estimates. That there's a rumor going around that sites cannot charge for their services. Obviously, if it's on your existing premises, we're not expecting you to charge us rent because those premises are your premises and they're already in existence. If you're renting a room in a hotel or somewhere, then we would expect you to say, yeah, this is my rental cost. We will work with you as best we can if those rental costs seem a bit skew. Okay, so that's an important thing. Equipment and consumables, when we walk into the premises, when we walk into your premises, our eyes will be drawn to how you store, manage, and keep your consumables and equipment. And that's as obvious as it sounds. Is your resource kit available? Is it there if somebody has an attack or needs support and assistance? Have you got the right level of equipment? Is your IT in place? Is it working? Is are your sharps bins full? Have you got them overflowing? Are they stacked unsafely? We will look at all of that. Now, what we would also say is, if you're going to sign an agreement with a landlord, don't sign up to a 6-month agreement with a landlord until you are absolutely certain that you've got the go ahead from NHS England, because that would be at your risk. Once we're looking at the site more clearly, we'll look at your staffing levels, and at a quick glance we can generally work out whether there are going to be any concerns or not. And I've listed the range of people there. We can come into we can talk later if you wish about who those people are and what they'll do. The golden rule for all community pharmacy providers for COVID is that you cannot adversely impact your standard pharmacy offering, whether you're a bricks and mortar 40-hour contract, you're a 100 hours provider, or whether you're a distance selling pharmacy. You must not adversely affect, and that will be by your availability or workforce. The marshals that you'll have, we'll also keep a look to see how they're operating. Are they doing the job that we need them to do? And again, I've listed a few bullet points on the things that we look for. And I think I don't want to repeat myself. So that's what we look at as soon as we're on the outside. So before I move on to the next slide, does anyone want? I see there's only about 16 or 17 of us. Does anyone have any questions that they want to ask at this moment in time before I'm moving to the next slide?
There is one slide in the chat, Umesh, I don't know if you've seen it or not. Can the implementation of phase 3 COVID be conducted outside the core pharmacy hours?
Yes, thank you for that. The answer to that is yes. Yes, of course it can. So if you're a 40-hour contract, because they have the lowest required hours, I guess, you can do, if you want, 12-hour days. You can do 12-hour days. Outside of your core hours, though, you cannot provide pharmaceutical services other than the vaccination service. Now, so that means you can't sell POMs, you can't conduct a pharmacy business beyond your contracted hours. That would be the only limitation I would put on that. Any other questions before Lou puts me on to the next slide? Oh, I think there's a hand up from someone there. I can see there's a hand up.
Yeah, from Chiman.
Oh, hi, Chiman.
Hi, you're right. Yep. The question I want to ask is, considering that you're going to roll it out to a lot of pharmacies as well now, and hopefully they'll all be engaged in delivering the COVID-19 vaccination, then you will only be serving your local population, if you see what I mean, yeah? So is it not possible to direct all the patients to via their local postcodes?
Sorry, say that again. I'm not sure I quite picked that up.
Considering that if we roll this COVID-19 vaccination to pharmacies, a lot more are going to come on board, yeah? So
Yeah.
You're going to have more sites locally available to do the COVID-19 booster vaccination, in which case, is it not possible to direct the patients locally, i.e. basically the pharmacies will be serving the local population rather than people traveling a lot?
Yes, thanks for that, Chairman. So this will be through a booking service, and as a patient, you'll go online and you'll look for a vaccination service that's ideally suited for you. So you can pick one near where you work. You can pick one, you might turn around and say, well, I want to go to Chiman's pharmacy. but actually Chimon's not operating on Thursday, and Thursday is my only day that's free. So let's have a look again. Oh, I can go to Betty's Farm. I don't know who Betty. If there's a Betty's Pharmacy, that's just a name that's made up. So I'll go to Betty's Pharmacy because it's, you know, and I want. So patients will all, in the same as prescriptions, you know, they can choose where they have their prescriptions dispensed. Patients throughout this process have always had the opportunity to go for a vaccine wherever they want to go. But you're right, the intention of bringing this back to high street pharmacy, community pharmacy, is to allow your local community to come to you. I mean, that's the desired outcome here. But any patient that wants to travel further can travel. So as a patient, I live in Bolton. If I wanted to have my vaccination done at Smith's Pharmacy in Birmingham, I can book on absolutely at Smith's Pharmacy in Birmingham and get myself vaccinated. I've just got to make sure I can get there. So there's no obstacle to where patients can go. But overall, Chimon, what we're finding is that patients don't like to travel if they can help it. One of the things that we will note is that a lot of patients in the early days were directed to the Mass Vac Centre in Manchester, even from Bolton. Those patients would ideally have preferred to have gone to a local pharmacy service, just for all the reasons you've mentioned. Have I answered your question?
I think so anyway, yeah.
Okay. Any more questions, please, you know, just keep open.
I've got some more questions here, but I think just one thing just to pick up on what Chimon was saying there, Umesh, was around there'll be lots more sites, and I think it's just we need to understand that sites will only be commissioned if there's a need in that area. So if there's already capacity is filled there, there won't be any more sites commissioned. It's not it's an expression of interest, isn't it? And that'll be matched against what is needed.
Lou, thank you. You've hit the nail on the head. And again, everyone, I'd just like to apologise because I'm so close to this, sometimes I forget what I know and what other people might not be aware of. So ultimately, there's a map of the UK which sets out where everybody lives, including deprivation, health needs, etc. And populations vaccinated, where people have had 1 or 2 vaccines, where people have had no vaccines. So we've got that general layout. Now, so if I was going to just refer to Chimon. So let's say you've got a shop, a pharmacy premises, and it's on the high street. And actually what we find is that there are 2 GP practices or 1 GP practice in that area, and they're already providing, then that population may be deemed served, in which case, even though we've got your EOI, we can't progress it because we've already got a provider in place. So what we've done on the previous waves 1 and 2, is we've sometimes been able to say, well, actually, that current provision is across a really busy road, or it's at the end of a very long road, and we still have a need in a subset of that population that isn't being met. So we would always still look to see if there's the opportunity. If you've gone to the effort of filling an EOI in and considering your options, we will try to place you. But as Lou's pointed out, if the area is already serviced, we don't want to over service, if that makes sense. So sorry, Lou, I'd missed that point altogether. Thank you.
It's all right. It's just a question that I'm getting asked quite a lot, so I thought I'd bring it up there. It seemed a good point to do that. There's one more question in the chat, Umesh. We anticipate to operate 24-hour weekend COVID injections. Can this theoretically be done as well as the core 40 hours?
Again, the answer to that is it depends on your workforce. So if anyone's going to be offering a 24 hours a day vaccination service, that must be able to operate without any impact upon the standard operating of the pharmacy. So immediately there are workforce issues here, because you're going to have staff operating in shifts throughout the day. Clearly, if somebody who's worked through the night can't then be expected to operate the pharmacy during the day. because both NHS England and the GPHC would call into question the fitness of that individual to provide a pharmaceutical service. So using that example, that somebody's example question, sure, if I had a pharmacy and I had 40 hours to operate, I would make sure that my staff in that pharmacy operated the pharmacy, and in the 24 hours around that 40-hour contract, so for around the 8 hours that pharmacy is open for the day, yeah, I would have to have different staff operating it. So your modelling must take into consideration what staffing you will need. And as I've mentioned on the previous slide, you're going to need marshals, you're going to need a vaccinator, you're going to have a clinical supervisor, someone who's actually responsible. So all of that. Now, to date, I can't think of anyone who's done a 24-hour vaccination service in the Northwest. But if it's a model that works in your area, then there's nothing stopping you. You're only, however, paid for the vaccinations you deliver. So if you don't get any vaccinations delivered between midnight and 7 a.m., you've staffed your site for no vaccinations. So it's just something to bear in mind. Is that right? Any other questions, or I'll just move on to the next slide. Okay, could I have the next slide, please, Lou? Okay, so this is getting your specifics together. So this is about the check-in point. Now, when a patient arrives at your pharmacy, you have to assume that they might be confused. It's not the case. Very few patients are actually confused, but patients will pitch up and say, I'm here for my second Pfizer dose. And actually, when you look them up on the computer, they've had an AZ dose or something different. So please anticipate patients trying to wrong foot you. We're all pharmacists, and and I think we're all familiar with patients saying the wrong thing. So when patients arrive, they'll say, hi, I'm here for vaccination. Make sure you're signposted. Make sure that you've got a sign saying that COVID vaccination this way, so they're not queuing up with a counter with all the other rest of the patients. Once you understand what they're there for, you'll have written information to give to them. So it might be about breastfeeding, it might be about the particular brand of the vaccine, and then you've got to have a check-in process where they're logged onto your system. So Umesh Patel has booked onto Lou's pharmacy for 8:30 on a Tuesday morning. I arrive. I can arrive 40 minutes early. I can arrive 40 minutes late. But believe me, patients will stretch your diary schemes. And the check-in process then logs me in. There's also got to be the ability for that patient to ask questions. Please don't underestimate, even though the scheme's been running for so long, every once in a while you get a patient who will take 20 minutes of questions. It happens. It's just one of those things. It's not a routine occurrence, but it can happen. And you will have to make sure that your vaccinator or your clinical supervisor can deal with that whilst the rest of your service can carry on flowing. And talking about flow, once you've gone through your patient journey, what I'll be looking for and what Monica will be looking for is that if my dad turned up at your pharmacy, at your vaccination site, that the flow for him is clear and unobstructed through from attendance, reception, checking in, getting jabbed, waiting for 15 minutes and leaving out. There shouldn't be any bumping into one another. So you need to sort your appointments in such a way that you haven't got too many people landing at the same time. And that then dovetails with the social distancing and safety for patients. One of the complaints that we get reasonably regularly is I went along to vaccination service X and people stood too close to me, or the staff were stood too close to me all the time. Now, when it comes to staff, yes, the person who's going to stick a needle in your arm does have to get close to you, but it's not required by any other members of staff. So can I have the next slide, please, Lou? Okay, so once we get in, we're looking at your consultation room. What does it look like? How is it laid out? Is everything handy for your vaccinator, and is it safe for patients? So one of the visits that I did to a vaccination site had a sharps bin next to where the patient was sat, and the lid wasn't on properly. There was a needle sticking out. So clearly that will be a risk to patients' welfare. So it's just making sure, think about health and safety for you and think about health and safety for your patients. You know, if I see overflowing bins, if I see overflowing sharps bins, you know, that it's never a great sign. We need some privacy. So if my mum comes along and it's a cold day and she's wearing a big thick woolly jumper and she's got to get her arm out, there's going to be a slight element of disrobing. It's not fully taking the jumper off, but, you know, getting the arm out of the sleeve. So we do need screens or the use of the consultation room so that my mum's not going to be too embarrassed. All the equipment, as I mentioned before, needs to be at hand. You know, your gels, your bio waste, your sharps, your cotton, you know, your IT. When you're vaccinating, before you get near the patient with the needle, you've got to collect all there's a pro forma for information collection. You must collect all of that information. It's all wonderfully laid out for you on the system as you work through the IT. And I think that's probably the easiest way of doing it. But some people do prefer to collect it on paper. But, you know, and I'm not going to direct you which way you go. If you collect it on paper, you collect it on paper. But once you've collected it, you must keep it and make sure it's not lost or transcribed incorrectly. There's one thing that is a bugbear of mine, and it's staff changing gloves. Your gloves are only for one patient. You change your gloves between patients if you wear gloves. Anna Swift from Wigan strongly recommends that you don't wear gloves because actually it's just simpler to gel your hands. You need to gel your hands after you've taken your gloves off and before you put your gloves before you put the next gloves on anyway, so you don't contaminate the outside of the glove as you're putting it on. So often it's easy just to be gloveless and gel your hands between patients. There's being bare below the elbow, so no wristwatches. That's an absolute no. No bracelets. You can wear rings. The vaccinators can wear rings, but they can only be plain rings. If you've got rings with stones or engraving, you'll need to remove them whilst you're vaccinating. And for anyone wearing false nails or with long actual nails, they'll need to come off. Not the whole nail by the roots, just trimmed to a sensible. And this is the same as any nurse on a clinical ward. So again, that's about infection prevention and control. So that's that bit. Can I have the next slide, please, Lou? Okay. Once patients have gone through your vaccination area, depending on the vaccination that they're having, well, actually, you know, if there are any driver needs to wait for 15 minutes anyway, there's an observation area. All patients must be advised. So before they leave the vaccination area, the vaccinator must just confirm with them whether or not they are going to have to wait. And if they are going to have to wait, how long they wait. The patient can then leave, and they leave knowing that they have to wait. Outside of the vaccination area, that they should be intercepted on their way out by a marshal who verifies that they're waiting. If they are waiting, they're then directed to the seating area. Now, if it's a relatively small community pharmacy, that's going to be very easy to do, and the vaccinator might be able to do that stage by themselves without a marshal. The patient must then know where they're going to sit and how long they have to sit. All seating must be socially distanced, so that's 2 meters apart. Now, there's a very good way of maximising the space in a community pharmacy or elsewhere, and you can have seats quite close together, but maintain social distancing by having clear perspex barriers between the seats, so they're lit effectively shoulder to shoulder. And fundamentally, it's the same as toilet cubicles, if you will, only instead of there being a toilet in there, it's a seat, a non-porous seat that can be wiped down, and the cubicle walls are clear perspex. That way, the marshals watching the patients for that 15 minutes can see and anticipate who's, you know, usually when you've done this for a while, you can anticipate who's going to faint, and you catch them before they fall on their face. Ideally. So that's about social distancing and observation. Marshals, again, another bugbear. I reasonably frequently, but not all the time, have to point out to site operators that their marshals are having a chat or wandering around and not watching the people needing observation. It's called observation for a reason. The patients must be observed. So your marshals must always be stood and sighted on the patients. You may wish to rotate your staff because, believe me, they'd almost be happier watching grass grow than standing watching patients for a full shift. Once a patient has got up out of their seat, before the next person can sit in it, it must be decontaminated between patients, and that has to be done immediately. And you know that there are wipes that are part of the supply system. Once my dad's got out of his vaccinations observation, it must be clear to him which way out. If it isn't apparently clear to everyone how to get out of the premises, the marshal must be able to direct patients to the exit. So I've really laid that on very heavily, and the reason being is I've not given you every nugget of detail, but those are the key points where sites can fall down. So apologies, please accept my apologies for labouring the points. Could I have the next slide, please, Lou? Okay, so in terms of consent, this is absolutely crucial. Only a registrant can take consent. Do not ever let a non-registered vaccinator or anybody else take consent. If a patient enters your premises, before they have their vaccination, they must speak to a clinician, whether it's a pharmacist, a nurse, a doctor, a physiotherapist, somebody with a registration certificate that you can rely upon, who can look at the patient, talk to them, and know when to ask more questions, and also somebody who can respond to questions about the vaccination, because you never know what questions. You believe me, some of the questions that you'll receive may seem quite extraordinary and possibly not related to the vaccination process, but it must be a registrant that answers that. If that's not the case, then the patients that have gone through your system are not deemed to have been, 1, consented, and 2, clinically assessed, in which case that will lead to I'll have no choice but to immediately suspend the service, subject to assurances being received. So sorry if that again sounds quite hard, but consent and clinical supervisions are absolutely crucial. Could I have the next slide, please, Lou? Okay, again, really major points. This is, somebody's leaving. We've lost Lou. I don't know what I've done. Let me see if I can share my slide. Let me see if I can share my slides. I have them for this emergency exactly, I think. Hang on. Bear with me whilst I oh, Lou, you're back. I've lost your slides.
Apologies, I got kicked out of the I don't know why.
It wasn't me.
I wasn't even touching the slides. Let me just get back to where I need to be. I can still share, that's good. If I couldn't, that would be a problem. Give me a second, I'll get it back up for you.
Marvellous.
I was going to say, I've got it as backup as well.
What happened there? I do not know what happened there. Sorry.
Thank you. No problems. No problems. Okay, so the next bit relates to PPE and IPC. I'll quickly whiz through this because you can read this at your leisure. First of all, is the space clean and clear? You'll all want to do this, but what we've noticed is that as sites progress, especially some of the GP sites, I hope I'm not being rude and insulting anyone, they can become a little bit complacent with their policies, procedures and cleanliness. Is the clinical supervisor, think about the clinical supervisor the way that you would think about an RP. Do they have control and grip of the site? Do they have oversight all the time? So if your clinical supervisor is vaccinating all the time, they can't also have a grip of the site if there's other things going on, if there are other vaccinators operating. Are your staff themselves breaching COVID regulations? Again, staff, volunteers can become a little bit complacent and stand just too close. Hand gels must be available for patients and for staff. Mask wearing is essential by all staff, and just make sure that you know all your staff know to nudge each other if their nose is poking out, or if they see a member of the public or a patient with not wearing the mask properly. It's just all those nudging. Waste location. So you're going to have two sorts of waste predominantly. Well, you're going to have three sorts. You're going to have your general rubbish, which is black bin bags. You're going to have your sharps bins, and you're going to have your bio waste, which comes in tiger stripe bags. All those must be away from the patients. We don't want anyone tripping, falling, or knocking into one of these things. Clearly, you'll have bins in use in the vaccination pod, but please just make sure that all your other waste is out of sight of the vaccination area. Make sure you refer to the PSNC's PPE, staff safety and security document. That I can't stress that enough. Where we see sites that are failing to deliver these things, or when we talk to sites that aren't able to describe these things when we go to do the sign off, we have to question whether or not that site can be signed off, because if we're at that stage and it's not something that you've thought of, so hopefully by telling you this now, you'll make a mental checklist of things to have, so when me, Monica, or somebody else comes along to you, you can go through these things to us and give us that assurance. Please don't make it just an exercise of telling us what we think we need to know, but please have that in mind. I'm just going to pause for a second and see if there are any questions before I move on to the next slides.
There's a couple of questions in the chat, Umesh. So one is, can patients wait outside in designated areas such as a gazebo or a marquee rather than inside the pharmacy?
The answer to that is a simple yes. Again, the gazebo or the designated area must be safe. Social distancing must be maintained. Patients shouldn't, there should be air. We should be able to allow airflow. Patients shouldn't get cold or hot. It should be allowed. And again, so long as that waiting area has adequate supervision. So you've got marshals on available to make sure there's wipe down, make sure patients aren't standing too close to each other or not wearing their masks, and patients know when to leave. And also, if there's any things like a delayed onset reaction, whether it's anaphylaxis, a seizure, or a faint, that it's not so far away that we can't get a registrant in there quick to put things straight. So was there another question?
Yeah, the second one was, can the implementation of a drive-through pharmacy be implemented with all signed consent for phase 3, like the initial COVID testing sites like in Manchester Airport?
Yeah, so we haven't ruled that out. What we would need to do is look at the application and how that's intended to be delivered. I've seen myself different suggestions for a drive-through service, and some of them have looked all right and some of them have looked different. We can have a conversation, but as it stands, we haven't got any sites doing a drive-through service right now. I can see someone's got the hand up. Is that Chimin again? Hi, Chimin.
Maybe a legacy hand.
Yeah, maybe. Yeah.
Okay, I'll lower hand. There we go. Chimin, if you still want to come back, please don't hesitate. Just put your hand up again if I've rudely put your hand down. Okay. Oh, Chimin's got his hand up. Sorry, forgive me, Chimin. I was so rude. Hi. Chimin. You're on mute, Chimin. Hi, Chiman.
Hi, okay, can you hear me now?
Yeah, I can hear you now.
Yeah, what I was asking was basically that while you're giving the COVID vaccination, you will be doing your flu vaccination as well. So presume you can give it at the same time.
So at this moment in time, we're looking at that. So I wouldn't assume that you can give it at the same time. I'm still waiting for JVCI clearance. Unless someone's heard differently. I've not been as close to that. So Monica, Lou, Lovejet, have we heard? What's the latest on that, just in case?
There hasn't been confirmation from JCVI yet on that status, as far as we know.
Okay, so Chiman, we'll find out when we find out. And usually with these things, I'll be honest, NHS England finds. I normally find out because one of the pharmacists has found out from looking at BBC News or something in the morning, and then sends me a message saying, "Oh, did you know?" So yes, so don't always assume that NHS England will find out first. But right at this moment in time, we're still waiting for that guidance. If it is allowable, then absolutely, so long as we've got safe systems in place to make sure that a patient doesn't get 2 COVID jabs or 2 flu jabs and actually gets the right COVID vaccination and the flu jab and the consent forms are in place, then if JVCI say that we can do that, then we'll work with sites to help them get to where they need to be to deliver that. If that helps. Is that okay, Chiman?
Yep, cheers, thanks. Yeah.
Okay, no dramas. Right. Could we go? Sorry, are there any more questions?
Not in the chat now, no.
Okay, so could I have the next slide, please? Okay, this is again another biggie. Vaccine management. Ultimately, we've got to avoid waste. I mean, fundamentally, a vaccine that doesn't go into a dose that doesn't go into somebody's arm is a tragic loss. Not just because of the cost consequence, it's just a potential vaccine that could have gone into a patient and improved safety. So we talk about post-vaccine observation, and I've talked about that. A part of the training that you'll give to your marshals and your volunteers will be about adverse drug reactions, how to spot a fainter. If you're lucky, the person will say, "I normally faint after a vaccine," or "I faint at the sight of a needle." They're a dead giveaway. The ones that make me wince are when I get an email saying, patient fainted in their chair, fell on their face, broke their glasses, smashed their lip, and chipped a tooth. You know, it's that kind of stuff, and it has happened, and it could happen. It's not the end of the world if it happens for you guys. Just make sure that your marshals were in place, and you know that they were observing. You can't ever predict how fast someone's going to faint, but most marshals will report that you can usually tell when someone's about to go. They get a bit sweaty. They just look different, and you'll know what I mean once you get used to it. So again, back to vaccine management. Pharmacists are beautiful. We do this better than anybody else. Safe storage and preparation of vaccine. This is absolutely what we excel at compared to other sites. What we also are good at is following systems. So vaccine preparation is highly specific. So you wipe the vial before you stick the needle in. If you're adding a diluent, you wipe the vial before you do it. Draw every dose out. You wipe the vial every time, the top of the vial, not the side of the vial. You don't knock it, you don't drop it. We're very good at that. There will be really clear instructions in the training, online training and guidance as to how to prepare the vaccine, but please do stick with it. Clinical governance, I don't need to labour that point. One of the things that we would need you to be careful of is remember that patients may have different vaccines. So at any one point, you might have 3 vaccines in your pharmacy. You must have systems in place to make sure that my dad, if he's coming in for his booster at your pharmacy, gets the correct booster. If you give the wrong vaccine, then it becomes a clinical incident. And it's not the end of the world. It's way below desirable, but it doesn't get you kicked off the system. It's not referral to GPHC. It doesn't, it's not that but you will have to fill in a local incident form, because remember, these vaccines are still under close scrutiny by the MHRA, and so there's a form that you need to fill in for every adverse reaction and every incident, including if a wrong incident. And touch wood, we've had precious few of those across the million plus that we've delivered by community pharmacy. Across the Northwest, we've had just a tiny number, less than 5. So you know, that shows you how rare it is. One thing that we need to manage is delivery of volume. So when I talk about vaccine management, there's going to be about how you handle. So if we send you 100 doses for the week, you've got to be able to try and get through those, and you'll do that by uploading 100, maybe 105 appointments online. Don't upload 200 appointments, otherwise you'll end up with 200 patients wanting to get a vaccine and you've only got 100 doses, and you avoid that like the plague. Storage and preparation, again, you know, I always mentioned that already. Waste, record keeping, we're all good at record keeping, we're all good at that. Patient space and flow, that's easy, I don't want to labour the point. Can we have the next slide, please, Lou? Okay, SOPs, protocols and confidentiality, it is absolutely imperative. So remember, we're giving an MHRA scrutiny product that is still effectively in late phase trials to patients. So what you will need to do is make sure that all your paperwork is absolutely up to speed. So every vaccinator must sign the SOP, the protocol and confidentiality agreements. If we arrive at your site and they are not there, it's not going to look good for you. You know, and it will be a significant concern for us, because it would indicate that you've not got your systems in place. It is far more serious than if you haven't got your branch SOP signed by your new pharmacists or by your new dispensers, because we can remedy that by saying get them signed, and then we can, you know, have a word about it and talk about that. In this case, you cannot go backwards in time to make sure that patients are vaccinated by somebody who has signed the document on it with an unlicensed product. So it is much more serious. Staffing levels, as per the questions before, they'll be absolutely crucial. It's a difficult balance to achieve and get right every time, because you might have 5 members of staff on it. If you've not got the patients coming through the door, you'll wonder why you've done that. But conversely, if you've only got 1 member of staff on and you're awash with patients, you will need to manage that patient throughput and stop patients coming in fast enough, and it'll be at your expense, if you will, to talk to the patients and say, look, I haven't got enough staff to deal with you. Would you please mind waiting? The wait might be about 5 to 10 minutes longer than anticipated. Generally, though, you will have uploaded, I don't know, 20 appointments for a Monday, 50 appointments for a Monday. You'll have 50 appointments booked up, so you know how many people are coming. You know you've got your fixed overhead. You've got to have your clinical supervisor. You've got to have your vaccinator. You've got to have your marshals. But then after that, whether you're running 1 vaccinator, 2 vaccinators, or 5 vaccinators, you just have the right number of people in for the number of vaccines that you've got coming through. Now, you don't just know the night before. So if I was opening appointments for the next week or the next 2 weeks, I put my appointments up, and on a day-to-day basis, I can see how many appointments are coming up next Wednesday or the next Thursday. So you're not having to book staff at the 11th hour. Training and record keeping, I've touched about. You've got to manage unplanned closures. If you're operating the vaccine service and your pharmacy site has an unplanned closure through staffing or wherever it is, or you have another branch that has staffing issues due to leading to an unplanned closure, that will look unfavourable upon you, because the first question we would ask is that because you've pulled staff away from delivering that pharmaceutical service? Clearly, if there's a fire, if a member of staff is hit by a bus, let's hope that never happens. Then that's something different. But if it's because your staff have been pulled out to operate the vaccination service, then that's an actual reason why we might issue with a notice to your contract. And again, that again links back into capacity and demand. Can I have the next slide, Lou, please? Okay, next one, patient queries. Every member of staff must know when to come to a clinical supervisor. This is no different to what this is the best thing about pharmacy. Pharmacy staff do this because you know what all your counter staff are trained, all your dispensers are trained, everyone in your pharmacy is trained, and it's the same. They must absolutely know when to seek support from the clinical supervisor. But just as an aside, you will get, I talk about odd questions. Your GP, patient's going to come to you and say, my GP said I should have this vaccine and you're trying to give me that vaccine. Or, oh, here's a letter from my GP. Please can I have this vaccine because my GP thinks I deserve this. Make sure, and I'm not going to go through the millions of different permutations and combinations of them, but just make sure that your clinical supervisor is up to speed with some of these. And again, the EOI process is a compressed system, but once you're hopefully one of the few that go, one of the sites that go through and is going to go ahead, between today and you going live, we'll be able to work you through some of these questions. Next slide, please, Lou. And there we go. Questions and answers. Sorry, it's I've been given the driest subject in the world ever, which is what do Monica and I look for. And I guess now, if anyone's got any questions, just raise your hand, shout out, or whatever it is we do in these circumstances.
I'll stop sharing screen so you can see people a little bit easier, maybe. We can see the hands raised, the things that have been chat a bit better.
Yeah. So I can see we've got 22 people in the chats today. What I would say before people start putting their hands up, I guess, and asking questions is our job. So I'm a pharmacist and I love to see community. It's always been my job to make sure community pharmacies are represented on the health landscape. Whilst I'm the commissioner, I would absolutely love to see loads of pharmacists come live. Don't let the things I've talked you through put you off. There are answers and solutions, there are workarounds. I can't help you fill your forms in, I certainly can't do that, but I might be able to give you some pointers. But like I said, the time frame is short. So that's my diatribe over. Forgive me, Lovejet, forgive me, Louise. Anyone get any questions?
It's just one question in the chat. I don't know if Lou's on mute. Do you want to do it, Lou? Sorry.
Yeah, sorry, I was just taking off mute there. Yeah, so there's a question here. With all the red tape, can we still gain your support to implement the service even though we are a distance selling pharmacy?
Wow. So I guess the answer to that is it depends what support you need. I'm not going to be able to tell you how to set your site up. So the commissioner provider split means that we set out the contractual obligations and the provider has to step up and say, yeah, this is how I'm going to meet it. I can help you between the start of EOI and the end of EOI. So if you come back and say, I think I'm going to have one vaccinator doing 5 patients at a time, I'll come back and gently nudge you and say, do you know what, that's not likely to fly. You might want to think how you do that. But what I can't tell you to do is to have how many vaccinators you must have for how many patients, etc. But the red tape is contractual clauses, which you'll all be familiar with your own job contracts and with your contractual terms of service. So it's no different from that. It's just a different angle. So yeah, absolutely happy to provide some support, but I cannot, as the commissioner, take you through how to deliver the service. I can fudge the edges by asking nudge questions or pulling a face if we're looking at each other from one to the other. But you know, there's a limit beyond which I can't go. So whoever asked that question, I don't know who's asked the question, but is that okay? I mean, raise your hand, ask the question, or pop a comment in, and then someone will read me the comment. Okay. So of the 22 odd people, I know my presentations aren't so good that you're all loaded with all the information you could ever want. I know that's not the case, because I know Monica will probably remind me after this that I've missed out about 50 items.
Not at all, but probably just to add to what you've said, it's around, this is not just one single process, this is an ongoing process. So you like phase 1 and 2, we've had many different waves, so pharmacies may not all be taken through the very first wave, but we need to have a list of contractors or providers that we can come back to. So it's just to be clear that it's not just one opportunity. It's one opportunity to put your expressions of interest in, and throughout the program, we will then be taking pharmacies through gradually if the capacity, when the capacity becomes available for areas. So just wanted to make that clear.
Yeah, thanks, Monica. I mean, that's a really good point. Once we have your EOI, we can keep that on file. So let's just say, so going back to the, I'll pick on Chiman because he raised a question before, and what I said was, you know, it's about locality. If Chiman puts an EOI in and there's 2 GP practices right near him that are providing the service, it's unlikely that EOI will progress, but we won't throw it in the bin. What happens if one of those other practices decide that they've had enough? Because you may or may not be surprised that sometimes practices don't think through their what's required of them. If they decide it's too much hassle and then they pull out, then immediately we'll come to Chiman, who was in that area, and say, are you still up for this? And we'll be able to articulate the number of patients, the workload, the capacity, etc., that we would need from him. So Monica's right, but when we come back to you, it'll be a very, here's a lot of information for you to think about. Sorry, Lovejeet, you got your hand up.
Yes, just a couple of comments in the box. So one, Mehran said, so DSPs are not excluded from the EOI process. Yeah, there's just a comment there, it's just confirming, so that's correct. And yeah. Khalid has come back with a comment saying still doesn't answer the question, but as pharmacy owners, we need support as everyone is learning how to support the government in implementing this. Can the LPC, NHSE and I support us in this?
So is this the same question as before about NHS English support? Yeah. Okay. So part of the support package starts here, which is the LPC running these events. The helpful documents that you received from the national team are what all the pharmacists in the country have had. GM was first out of the blocks, with courtesy of Lovejeet and Lou, to run and operate this engagement meeting and make sure that Monica and I attended. To provide insight and support. So yes, there is always going to be that element of support, but it's a very generic question, and I'm not sure what specifics are being asked. So we can't tell you which forms to fill in and how to fill them in, you know, because that's yours. If you're unable to fill those forms in without asking for help, we probably don't want you, to be perfectly blunt. And that's not meant to be rude. Part of this is a beauty parade for us to choose sites that are going to be able to demonstrate their capability to do it. If we're having to physically carry people over the line, then it's not our ideal situation. Sorry, mean commissioner, sorry. Oh, there's a hand up.
There's 2 hands.
Finn McCall was first.
Oh.
Yeah, Umesh, sorry. Number one, thank you very much for giving us your time, and Monica tonight, to share this. And I just wanted to come in and support you with that statement. I think the sheer fact that you're coming out and giving the LPC and giving contractors all this information in advance of the deadline for the expression of interest is phenomenally helpful. So I think you're already way ahead of the game, and I think as contractors, we must take some onus ourselves that if we're serious about running this and sorting it out, we need to then learn from what you've said and go ahead with it.
Yeah.
So thank you.
Thanks, Finn. As a pharmacist, I'm desperate to get pharmacy right front and absolutely front and centre. Yeah. Was there another hand? Did I miss that?
Yeah, Mohammed Shafiq has got his hand up as well.
Yeah. Hello, it's Usman. Yeah, just wanted to reassure Khalid there will be plenty of support available from LPC and NHS England. I mean, as a obviously we have done this. We have been doing this since last 7-8 months now, and we have had excellent support from LPC and NHS England both. Obviously, there are patrons, like, you know, if you need a help from, you know, you need a tech help, there will be a separate desk for it. If there's a legal help you need, there will be separate people for it, but there is plenty of help available.
Thanks for that, Usman. That's nice to hear. Thank you very much. Are there any other questions? I feel like either people have fallen asleep or they're don't be afraid of me. I might look fearsome, but I'm not really. Usman's going to object.
Oh.
Hi, Usman.
No. So sorry, that was, you know, by mistake. Sorry.
Okay. Yeah, I got all excited. I thought we had a question. Loved you. I don't know. I mean, how do we beat questions out of the attendees?
We don't have to beat questions. I had a couple of questions from contractors, actually. Is it all right to ask them?
Of course.
Finn's got his hand up though before that again.
Yeah, Finn's come to bail us out.
No, well, I mean, the form is quite vague.
Yeah.
And I was traveling on my way home earlier on when you mentioned the form, but I suppose how much is enough detail and how much is too much and how much is not enough. So some guidelines around that, Umesh, would be helpful. And I know you're going to say sort of enough detail to help us understand what you're trying to do, but any guidance on this, that would be really useful.
Yeah, and I've had, and thanks for that, Finn, because, you know, for phase 1 and phase 2 we had the sim. You know, you're quite right. We did have similar questions. What I would say is try to keep if you are making points on your application, it's a web. If I remember correctly, it's a web form, isn't it? That you fill in online and it populates. You fill in boxes. Yeah. So it'll be word questions, and it's not. There are very few yes/no answers. I think the majority of it, if I understand this, is where you write in some text. If you've got a lot of information to put in, put it in, but keep it as bullet pointed as you possibly can, because I think that carries it. It's easier to retain in the reviewer's mind a picture for your application. So Finn, if you put an application in and you write, 100 words when you could have put it into, 15 or 20, 5 or 10 bullet points, that those from our perspective, reading it, 5 to 10 bullet points is just easier for us to retain when we're doing our assessments, and when we need to flick back, it's easier if we've got things to put in. So I'm just thinking of questions that will be on the form. One of the questions will be about workforce, and it will probably say something along the lines of, can you demonstrate or have you got workforce to deliver this without impacting your without impacting your pharmaceutical contract service? And the answer to that could be as simple as yes, but I'll just look at that and think, oh, crumbs, that doesn't tell me anything. So in the ideal world, you'd be able to just a few words about yes and who these people are. You don't give names, just we have, we're a 3 pharmacy business or a 1 pharmacy business or a 20 pharmacy business, and we've got this many locums we use routinely. They're all prepared to do vaccination training. We've got members of staff who act as volunteers, or we've got a local community group that will offer volunteers, or will use St. John? You know, so what you're doing is then you're giving me what I'll be looking for, and please give me as many hooks as you can to hold on to. The more hooks that you give me to hang on to, the better it is for me. And hooks are best pointy and short. So sticking to my example, Finn, the workforce question, you know, an estimate of the number of vaccinators you'll have, whether they're going to be registrant or non-registrant vaccinators, how many registrants you'll have, how you'll be able to give assurance that they'll all be trained, whether or not there's going to be one of them that's the clinical supervisor. If one of them is going to be a clinical supervisor, how you're going to identify them, what will that leadership look like? So it can go on and on and on, and I'm in danger of making it sound longer than it needs to be, but I'm trying to just scratch away there. Sorry.
Yes.
Really helpful.
Question in the chat: do we have to provide the service 8 to 8, or can it be done during pharmacies' opening hours for 100 vaccines capacity, for example?
Yeah, that's a good point. So with phase 1 and 2, the enhanced service required every provider to be available 8 till 8, 7 days a week. Okay. Now, if we gave those providers enough vaccine for 1 day, there was no point them sitting there for the remaining 6 days, 8 till 8. So we never enforce that. We have enforced it a few times across the Northwest because we needed patients to be seen. But the answer to that is no. So if you're only doing 100 vaccines, as an example, we won't need you to open outside of your, it's unlikely that we'll need you to open outside of your contracted hours. If your contracted hours are 9 till 5, and actually you're not getting enough patients through the system, then what we might do is we might say, try and change the dates that you're available. And if that doesn't grab people in, then we would suggest change the hours that you're available. But again, we're not there with a big stick. Our job is to try and support you. And between Monica and myself and the rest of the team, we'll get a flavour from the other side as to what is working. And, you know, we will always try to feed that information back to you directly. Talking about other sites, there is an existing Greater Manchester Pharmacy Providers Group. We meet every Wednesday. I'm hoping that with phase 3 we can continue that. I chair it, but not because it's my group. It's just none of the pharmacists that whose group it is wanted to chair it, so it came back to me. So first, please, if any of you are good at chairing meetings better than me, you know, there's a chairmanship job right out there for you. But it's your meeting and it's your opportunity to talk to NHS England, send us messages, turn up and present it, and then have us discuss it. You don't have to attend every single meeting. The meetings last between 40 minutes, an hour, and it depends how juicy the conversation is. And we have all sorts of stuff like the IT is not working. What do we do with these sorts of inquiries? Can we, and then you can ask questions about regulations and rules. It's your meeting, and NHS England there is there only to act as support for you in every way that we can. If you admit to murdering someone and hiding them under the stairs, can't help you.
One question that I've been asked, Umesh, a few times by contractors now is, do we have any early indications of what the need is going to be? I suppose, do we have any ideas that we know PCNs are going to be stepping down? I think, obviously this is the big piece of work, isn't it, just to submit the EOI. And if actually there's absolutely no chance they're going to get chosen or get selected to provide the service, they're a bit reluctant to invest in that. Do we know anything at all, or is it just at the moment it's just speculate and see what happens?
So in the Northwest, there are some CCG areas where the PCNs have already declared that they're not interested. So Warrington, for example, they've just said, you know what? We didn't enjoy that at all. We're not doing it. So we're Greater Manchester, so you know that's not the same here. Of course, it wouldn't be that easy over here. Why would it? But the closing date for pharmacies EOIs next Tuesday. The closing date for GP submissions is Wednesday. So the earliest that I'll find out is Wednesday. Some places might be making sounds, but the one thing that I can tell you all is just because practice say, yeah, we're not interested in it, or yeah, we are interested in it, is not the sounds they make today has no bearing on what actually happens.
So when GPs, well, when we get to next Wednesday, I suppose the next question is then, and the GPs have opted out because they have to opt out, don't they? I believe they don't expect an interest to be in. If they've opted out, is that it for them? Can they at any point then come back and say, "Oh, we want to do it now"?
The answer to that is the GPs can. You know, dropping all my Northwest colleagues in it, we call it doing the hokey-cokey. They can say, we know we're not interested, but then at a later date insist that they should be included. I think for them, they will find it difficult getting back in if they've said no in the first instance, but they seem to have a view that they might be able to do the hokey-cokey again in phase 3. That's going to be tested if they do.
Excellent. I think Finn's got his hand up again. Sorry.
Yeah, sorry, it's probably not related. Well, it isn't definitely not related to the activity of giving the COVID vaccination program and signing up for it. But there is the added complication this year around the flu potentially being given at the same time. Now, I know that will be burning question on some of my colleagues on the call tonight around what happens if I have too many flus, not enough flu jabs purchased. Is there any sense of any organisational support coming for people with regards to accessing flu jabs, or indeed trying to get contractors and GPs to work as a sharing resource across the PCN, working collaboratively on that side of it?
Yeah, it's a good point, that, Finn. We raised this as the Northwest, and we asked the national team about this, and the answer that came back was typical central team response, in that there is sufficient flu vaccine in the system for all the patients that will need flu, which is not especially helpful, because what that means is they've looked at how they've spoken to the suppliers for the number of doses, and you know that's the aggregate of the vaccine that's available in the hospitals, to the GPs on order, and to pharmacies on order. What I would want to move towards within GM and the Northwest is having exactly what you've described, which is some sort of collaborative approach, working within the ICS structure. The ICSs hopefully will be a different beast to the CCGs. The CCGs operated in one particular way. The ICS will be much, I'm not allowed to say this officially, but be much more like the PCTs, in that they can have a stronger say over what people desire. You know, people can express their desire for doing something, but the PCTs and the ICSs in the near future will be able to dictate how that will actually roll out. So the short answer to your question, Finn, is no, there's nothing in place and agreed now. The longer answer is we'll be looking and expecting contractors to work together, whether that's the sale of vaccines. So if Monica's got loads of vaccines she's not used, can I buy them from her? I mean, that could be a really simple solution. Another way of doing it would be, sure, Finn, you've got loads of vaccine. Umesh, you've got loads of patients. Just send your patients to Finn. Would be a way forward. The underbelly of this is that some practices have a very fearsome grip of their annual flu vaccines. Do you know? And you know, your mileage may vary on your relationships may be a bit tense.
Absolutely, and to be fair to the practices, they've invested in that stock today, and they've counted on that income as part of their annual budget.
Yeah.
So, yeah, and I think that more we can talk around a collaborative model and use this year to try and sort it out. I'm just going to flag up that one of the largest suppliers or the wholesalers for independents in the Northwest doesn't look like they're going to have their annual flu jobs this year. So that will put us in the Northwest at a risk.
So Finn, does that indicate that there's orders in with that supplier that aren't going to be able to be honoured?
Yes, but can we take it offline? And
Sure.
on the next few days. So I just
I'll
wanted
start
to flag
sweating a
that.
bit now.
Yeah. I know my fellow contractors will go, yes, my orders have been cancelled, but rather than go into the details, we'll
Sure.
chat about it. Okay.
Sure. Thanks for that, Finn. Yeah. Lou, were there any other questions from?
Can't see anything else in chat. I think we've covered everything there. Unless there's any more questions, there's no hands up at the moment. Yeah. You feel free to speak, people. You don't have to. You don't have to just put it in the chat. Put your hand up, and we can take questions that way as well.
Yeah. It's your opportunity to pick the brains of the experts here and get your advice in.
You actually get this opportunity. Do we love Jet? I think we've been very lucky to get Monica and Ramesh here tonight. So yeah, do make the most of it.
Yeah. I mean, what I've tried to do is I've tried to do the whole poacher turned gamekeeper thing. So my day job is to check standards. And it's a bit like asking a policeman to come around to your house and say, you know, where your security issues might be, because they've seen it so many times where people break into a house, you know, through that window, that lock doesn't look very safe, get a night light, get a CCTV, get an alarm. So having seen lots of sites either running brilliantly well and at the other end of the spectrum less well, between Monica and I, we've seen where things can go really, really well and what that looks like and when things don't go so well. So yeah, I mean, we'll be available. If there are any questions that you think of after the meeting closes, please let Lou know, and between me and Monica, we'll come back and we'll try and respond to those. Oh, there's a hand up.
Ishmael's
hand up, yeah.
Yeah, just asking, you know, after the EOI, when are we expecting visit, and also, you know, to make the premises suitable for the service, like you explained that, you know, we can use like Perspex screen. Like, is there any support available, or do we know where we can get them Perspex screen?
Okay, so helpfully within GM, if I start with that second question, there are currently 21 providers out there that have gone through all of this, and Usman was on in the meeting earlier. So they've all had to work their way through and find providers. So there is actually a group which is entirely your own group, you know, pharmacy providers group, and I think Aneet Kapoor operates a WhatsApp group where you can ask questions of each other, and so Ishmael, there's every opportunity for you to go and, you know, have this answered by the other providers that have been there and done that. I don't personally know who supplies what out there, so that's the first part of the question. And having answered that, I forgot. That's the second part of the question, but I forgot the first half of the question now, Ishmael.
You know, when are we expecting the visit, you know, to check the premises whether it's suitable or and other stuff?
So the answer to that is it depends on how many EOIs that we receive. If there's no cloning technology yet, so I've only got me and Monica really, and there's, you know, there's still only the same GPHC inspectors. So we can only get to you when we can get to you. In the ideal world, we'd want to see you in the week before you go live, which gives you all the opportunity to get your site and premises ready. You know, and again, the other providers will be able to help you with that. We might be able to give you some nudges as well. If we're unable to do that, we'll do it virtually. We can do it by Skype, WhatsApp, video, Teams video conversation. And you know, the way I've done that is the other person just basically we have a WhatsApp video chat, and I'll say, show me that corner, show me that corner. We can have a chat. So it's as good as, almost as good as being there physically and in person. So there's different ways of skinning the cat. No cats were injured. No cats were injured in the making of that. I don't know if are there any more questions, or do you want to email Lou and Lovejit in your own time once you've had a think?
Put our email in the chat so that you've got it. Lou, you put your email, and if there's any questions, that I'm sure Umesh and Monica will be coming to you as well for help, but we'll field the questions as well.
Right, marvellous. Okay, well, thank you all for having us. I mean, me and Monica don't get out as much as we used to do, so it is nice to do something a bit more normal. Oh, you're on mute, Monica.
So just to add to that, the session is recorded, so it will be posted. So if you didn't, because a number of people weren't able to log into it from the very start, it will be available. Not sure where to be posted, but we'll let you know.
And thank you very much, Monica and Umesh. We really appreciate it, both at LPCs, and I'm for sure contractors are really, really grateful for this insight. So thank you very much.
That's my pleasure. Okay, well, have a lovely evening, everyone. Sorry it got a bit late.
Thank you. Take care, everyone.
Yeah, take care, everyone. Thank you very much.
Thanks, guys. Thanks so much.
Thank you. Thank you, guys.
Louise, can you just stay on for me for a couple of minutes?
Yeah, no problem at all. Yeah.
I won't keep you long. I know it's been a long day.
It has. Every day's a long day at the moment. It's just.
Right, the session was recorded, that's fine.
If you stop the recording now, Monica.
Well, it says dismissed. So is that what does that dismiss mean?
It is still recording.
Okay.
You can stop it in the top right hand corner, in the top left hand corner, I think.